My name's Andrew Sloane. I teach Old Testament and Christian thought at Moreland College. My background is originally I trained as a doctor, but I've been working in theology and theological education for many years now. And my interest in this broadly comes from my shared interest in medicine, in theology, and what it means to be faithful Christians living in the world that God's placed us in. So the job I'll be doing this morning is speaking generally about what moral injury is, how we can best understand it, and also how we can differentiate it from other things that we might come across, because our response, I think, ought to vary depending on, if you like, which category our experiences fall into. Now, it's fairly clear, I think, to most of us that the COVID-19 pandemic has raised many complex issues in medicine, public health, politics, the economy, work and life and relationships, even how we find rest and relaxation in a time of stress. The pandemic has also thrown many equally complex moral dilemmas our way. How do we balance risk to vulnerable people from the virus and from lockdown? Some of those dilemmas are obvious. Isolated elderly people, people with disabilities and others who need care, the mental health issues that have been thrown up over the last few months. Others are not quite so obvious. Disturbing increases in substance abuse and in domestic and family violence. The unexpected, well, I guess they shouldn't have been unexpected, effects on workers and residents in aged care facilities. Other questions like, how do we balance public health and economic fallout? The loss of income and changed living arrangements for casual workers, for young people trying to enter the workforce, the impact on small businesses, especially in hospitality and tourism. But balancing that with risks in transmission in social gatherings, the transport of the virus across regions. Questions like, how do we allocate resources, scarce medical resources, and who has to miss out? And how do we then live with the consequences of decisions we're forced to make, the mistakes we might make, and the wrongs we might commit in the process? We face a prospect, or perhaps a current experience, of moral dilemmas, bad moral luck, moral distress and associated moral residue, and even moral injury. And they're the categories I'd like us to consider this morning. Now, I'm a theologian. I have interest in Old Testament, ethics, philosophical theology, and with a particular interest in bringing theology into conversation with medicine and the sciences. And so that means I'll be thinking theologically about these questions. But good theological reflection requires that we think through implications and application. So we'll do a bit of that. But it also requires that we understand clearly what we're trying to make sense of. All too often as Christians, we run in to say things about stuff before we understand the stuff we're talking about. So let's try and get clear about the kinds of categories that we ought to use to help us to think through these complex matters. The first category is moral dilemma. I think we're pretty familiar with that. Anyone working in healthcare faces complex situations in which it's either not clear what we ought to do, or perhaps there are two or more mutually exclusive options between which we must choose. This is particularly prevalent in intensive care and emergency care settings, but elsewhere as well. I mean, a classic instance. You're working in intensive care, you have one ventilated bed available, but two patients who might benefit from it. Sarah has no underlying health concerns and stands a good chance of making a full recovery after a short stay in ICU. Malcolm has complex underlying health concerns involving multiple systems, including his lungs, and would require a prolonged ICU stay with little chance of making a good recovery. Sarah gets the bed. Or it could be very hard. Neither Sarah nor Eric have underlying health concerns. Both stand a good chance of making a full recovery after a short stay in ICU, but only one of them can get the ventilated bed. In such cases, these are dilemmas that some of us have to face every week, if not every day. In cases like this, We do our best to make a good decision, even if it's not the only or the right decision. And while we might feel grief at the human cost, while we might mourn the harms that result to some people because of the decisions we must make, it seems to me that we should feel neither guilt nor shame. But we might. And if we start to feel those things, it's a matter, I think, of figuring out a better way to assess them, a better way of understanding what it is that we have done and what we've gone through. We'll talk about that a bit more later. Because that's connected with the next category, which is probably a little less familiar. This is what's called bad moral luck. Somebody who misses out on an ICU bed is, in some respects, the victim of bad moral luck. But those who are actors in circumstances sometimes also experience bad moral luck. It's really hard to define it. There have been a number of attempts to do it. None of them are terribly satisfactory, but it's easy enough to see. It's where a bad thing happens that's not subject to someone's control, even if it's the result of their action. Think, for instance, of a bus driver, a well-qualified, careful bus driver who's driving carefully and legally through a suburban street, and a child chasing a ball runs out in front of the bus, is run over and killed. That's bad luck. Or a surgeon or physician who treats their patient according to the best practice guidelines, but the patient dies as a result of a rare, unavoidable complication. It's not their fault. It's just terrible moral luck. They rightly feel bad. The bus driver, the physician, the surgeon, they rightly feel bad. This is what's come to be called agent regret. But we need to think carefully about how they feel bad and why they feel bad and what they feel bad for. Two distinctions are important here. First, there's a difference between wrongs and harms. We wrong someone when we knowingly, particularly, but sometimes unknowingly, we wrong them when we treat them in a way that fails to acknowledge what is owed to them, particularly to humans as persons made in the image of God. We harm someone when we injure them, physically, or their psyche or their reputation in some way. The bus driver wronged no one. They certainly harmed a child. It's entirely appropriate that they feel regret for the harm that they have done, but they should not feel guilt for it. Regret needs to be distinguished from guilt, even as harm needs to be distinguished from wrong. And in that regard, I think it's important to recognize that we're finite beings with limited capacity, relevant, of course, also to the dilemmas we were talking about earlier. We have limited capacity and limited control over the world. Again, that's something that's worth our while thinking a bit more later. This brings us to the third category. So we've talked about moral dilemmas, talked about bad moral luck. I want to now talk about moral distress and moral residue. Now, Gabi will be talking about this as a nurse. This is where the term comes from. In clinical contexts, this notion, moral distress, might be best described as ethical unease or disquiet resulting from a situation where a clinician believes they have contributed to avoidable patient or community harm through their involvement in an action, inaction, or decision that conflicts with their own values. There are a bunch of things that are important there, including avoidable patient or community harm. Notice how that differs from, say, the dilemmas or the bad moral luck that we were talking about earlier. Now, as I mentioned, the origins of this notion lie in nursing literature and identifies a number of elements that are crucial to moral distress. First of all, it arises when someone believes that they know the morally right thing to do or to avoid doing, but their ability to do this is constrained either by internal or external factors. The external often, very often, are institutional factors. That's the first thing. Secondly, it comes in two phases. There's the initial distress at the time of potential action or inaction. And then there's a later reactive distress, or what's come to be called moral residue, that occurs in response to the initial episode of moral distress. And the third element is that it involves the compromising of their integrity, their moral integrity, or the violation of their core values. Now again, things can get a little tricky here in relation to, say, bad moral luck or moral dilemmas, because sometimes it seems as though the decisions you have to make seem to violate some core value, respect for persons. But differentiating that from these circumstances, I think, is important, because there it's not a forced choice between two possibly good options. It's a forced choice to a bad option. Now, in the nursing literature, this is seen as first and foremost a practical problem. And its problematic nature largely consists in the adverse effects it has on the well-being of nurses, quality of patient care, and nurse retention. So interestingly, it's fairly utilitarian in its focus, which is not surprising, I guess, in our context. It does show a concern for the well-being of nurses, but also the well-being of the profession, nurse retention, and of course, the benefit of patients. So moral distress can give rise then to moral residue, and these two notions are closely connected to each other. And it's stated this way: in situations of moral distress, this is a quote, one's moral values have been violated due to constraints beyond one's control. After these morally distressing situations, the moral wound of having had to act against one's values remains. That notion of moral wound, I think, is important. Moral residue is long-lasting and powerfully integrated into one's thoughts and views of the self. It's this aspect of moral distress, the residue that remains, that can be damaging to the self and one's career, particularly when morally distressing episodes repeat over time. Something, of course, that's become almost a daily feature for some people during pandemic. The result is tragically that it can result in moral numbness, where people no longer feel able to both experience the moral weight of what they do or respond appropriately. It can lead to burnout, or, and this is problematic for some people, it may not be for us. Again, something we might like to think about. It can prompt conscientious objection, where someone comes to recognize that these kinds of behaviors, these kinds of circumstances are not ones that they can rightly enter into. So moral dilemmas, something we're familiar with, bad moral luck, moral distress, and associated moral residue, brings us finally to moral injury, which is, I guess, the key focus of what we're talking about today. Moral injury, and I would argue that moral injury can be a consequence of acute moral distress, which is the way it's normally been talked about, particularly in the military literature, or I think as a result of chronic moral distress. Moral injury can be defined, again, I quote, as a profound psychological distress which results from actions or the lack of them which violate one's moral or ethical code. Notice again, a focus on actions or inactions, and notice again the importance of violation of one's moral or ethical code. Now, it's worth noting that the category was developed in response to the experience of combatants in the armed forces, particularly US soldiers returning from the first Gulf War, where the experiences were very acute. Shea, who coined the term in this context, included a clear institutional element. And again, that's relevant for us in healthcare settings as well. Here's his influential decision. Again, I quote, moral injury is present when, one, there has been a betrayal of what's right in the soldier's eyes by someone who holds legitimate authority in a high, second, by someone who holds legitimate authority, and third, in a high stakes situation. Moreover, again I quote, moral injurious events can include acts of perpetration, acts of omission, or experiences of betrayal from leaders or trusted others. Unlike PTSD, moral injury is not a mental illness. Moral injury also is not limited by context or profession. For example, a recent review found that exposure to moral injury was significantly associated with PTSD, notice associated, it's not the same thing, depression, and even suicidal ideation across a range of professions, teachers, military personnel, journalists, across a variety of countries, USA, Australia, Israel. Moral injury. It's always pertinent for Christian healthcare professionals, particularly in contexts where hard decisions are having to be made in a context of overwhelming need and the allocation of finite health resources. Some of that moral injury may be unjustified. And again, that's something we might like to talk about later. So there are the categories. How might we respond? And again, this is something we will talk about some more later. The first step, I think, is to recognize the importance of truth-telling. People need to acknowledge what they've done or what they've witnessed and the way it has affected them and affected others. But they also need to interpret those experiences correctly. No matter how complex their feelings are, it's important to get this right. Is this an occasion when someone has been wronged? Or have they been harmed only? Or perhaps both? And it's important to acknowledge the psychological and emotional impact and receive appropriate support and counselling, which is a second and vital step. Now, while psychological support and counselling are helpful, they don't address guilt and shame particularly well. That, I suspect, is because moral distress and moral injury are real spiritual phenomena, as well as psychological or existential experiences. And that means they need a spiritual, theological, as well as a personal or psychological response. Church communities ought to be places where that support can be found and where people can be pointed to the grace of God in the gospel, and organisations like ours. Now, while the gospel is the best spiritual therapy I know, there are some ironies here. And we need to be very careful. Because while we might seek spiritual care as a means of dealing with distress, it's unlikely to work if it's only a therapeutic strategy. Moralistic therapeutic deism is as dangerous here as anywhere else. But we also need to recognise the diverse riches of what the gospel has to offer us and discern what kind of response is most appropriate. In cases of bad moral luck, people need to be able to articulate their agent regret, to lament, to mourn the harms that have been done and their role in them. But also recognise that while lament is appropriate, confession and repentance is not, because guilt doesn't apply. Now, that will also be helpful in cases of moral distress, that notion of lament, moral residue of moral injury, but there may also be appropriate guilt for wrongs committed or permitted. That needs to be confessed, and the forgiveness of the gospel received after appropriate remedial actions. As to the experience of cleansing and transformation that the Spirit can bring us. But finally, bigger questions, institutional issues need to be identified and, where appropriate and possible, dealt with to avoid unnecessary repetition of these injurious actions. Moral dilemmas, bad moral luck, moral distress, moral injury, complex things, but things I think the gospel gives us resources to address.